Hi, everybody. It's Rachel here, and I'm going to be talking about pedophilic disorder. So, I know that you all need to watch this video as part of the course requirements, but I still want to start just by saying trigger warning. I won't be getting into too much detail, but this topic can be difficult to listen to or think about, so I just wanted to put that out there to start. So, some clarifying definitions. Child sexual abuse is adult sexual contact with an underage minor, while pedophilia or pedophilic disorder is a psychiatric disorder involving involuntary sexual attraction to prepubescent children. So, this is really important to note that not all child sexual abusers have an interest in prepubescent children, and many suffering from pedophilic disorder have never acted on their sexual desires. So, lots of people immediately think of child sexual abuse when they think of pedophilic disorder. This is problematic because it increases stigma tremendously. This is one of the most stigmatizing disorders, and many suffering from this disorder don't seek treatment precisely because they're afraid that people will think that they're a child sexual abuser. So I saw this online plea on a website called Virtuous Pedophiles that I'll talk about at the end of this presentation. But I thought that this passage really highlighted the stigma that I just mentioned, as well as the difference between the disorder and child sexual offending. So somebody wrote, I'm a 20-year-old man who has been trying to deal with an attraction to young girls since I was 13. Women just don't interest me. I wish with all my soul that I could have a brain that's wired normally. I know that I can never act on what I feel, but I need to speak to a therapist because I don't think I can get through this on my own. But if I talk to a therapist, he could report me because I have to talk about my attraction to young girls. I don't know whether he would or not, and don't even know how to go about getting more information. Even the friendships I have are in danger of falling apart because I can't just keep saying I'm fine and I can't talk to anyone about my problem. I think about suicide a lot. So, like I said, this really highlights the stigma and how damaging the stigma could be to somebody who has this disorder. Um, and it also highlights the difference between having this disorder and then offending. Like this person never offended and doesn't want to offend. So, DSM 5 diagnostic criteria for this disorder. A, recurrent and intense sexually arousing fantasies, sexual urges, or behaviors involving sexual activity with a prepubescent child or children, generally aged 13 or younger, lasting for at least 6 months. So again, I'm just differentiating that prepubescent is age 13 and under. This is quite different than age of consent laws, which, falls in the realm of the child sexual abuse. B, the individual has acted on these urges, or the sexual urges or fantasies cause marked distress or interpersonal difficulty. So again, they don't have to act on these urges. They can have distress and impairment, like the passage that I just read. C, the individual is at least age 16 and at least 5 years older than the child or children in criterion A. And the DSM notes that we should exclude individuals in late adolescence in an ongoing relationship with a 12 or 13-year-old. And specifiers are exclusive type, being attracted to children, versus non-exclusive type, being attracted to both children and adults, sexually attracted to males or females or both, and whether or not it is limited to incest. So just a brief history, and again, this is a brief history of the disorder and not of the crime. Pedophilia is thought to have occurred throughout history. So if you think about like ancient Greece, when teachers and pupils had sexual relationships, in 1896 was the first time the term pedophilia erotica was coined by a German sexologist and physician named Richard von Krafft-Ebing. And the word itself originates from the Greek words pedos, which means child, and philia, which means love. Then in the early 20th century, Freud and some others continued to discuss sexual attraction to children. Also, interestingly, the progressive era in the early 20th century brought about a moral sexual panic, which focused on pedophilia as well as some other issues. And this wasn't a result of more abuse of children per se, but it was instead a function of prolonged childhood and adolescence for the first time, as well as anxieties over things like mass immigration, divorce, child labor, and juvenile delinquency. Also feminism, actually, first wave feminism. So all of this culminated in 1952 when pedophilia was included in the first DSM, Initially, it was a subtype of sexual deviation, and then ever since 1952 through the DSM-5 today, it became more and more descriptive over time. So course and prevalence, the population prevalence is unknown, and this is because this disorder is so stigmatized that many people don't report it. The highest prevalence reported in males is 3 to 5%, and females likely only a fraction of the prevalence in males. Onset is about the age of puberty, and this leads some to conceptualize the disorder as a sexual orientation. There's some controversy around that. Actually, when the DSM-5 was first written, there was a typo made where it came across as the DSM noting that pedophilia is a sexual orientation, but then it was changed, so there's some controversy there. The attraction itself tends to be lifelong, but the disorder is not lifelong. So treatment can affect changes in acting out behavior as well as distress and impairment, which makes the disorder change. Prognosis, so overall, research does not suggest that the attraction to children can change. However, treatment can reduce offending behavior as well as distress and impairment, like I just said, and therefore it reduces satisfying criterion B from the DSM-5. If pedophilic disorder is comorbid with antisocial personality disorder, individuals have a higher likelihood of acting on their attraction. Some cultural considerations. So interestingly, and just, it's something to think about. It's a pretty complicated topic and controversial idea, but the boundaries that dictate appropriate and inappropriate sexual attractions in general are themselves social constructs. So paraphilias have in the past been described as fetishes, deviances, or sexual minority behaviors. Although such classes of behaviors are prevalent across all nations, cultures, and societies, they may in some cultures be considered normal. So just like different, components of sexuality itself are social constructs, so too paraphilias. So some cultural examples, I already mentioned ancient Greece. We also have child brides in different cultures. And then one of the most well-noted examples of a cultural consideration for pedophilic disorder is that the hetero believe that young boys must ingest the semen of their elders daily from the age of 7 until they turn 17. And this is to achieve adult male status and to properly mature and grow strong. So I don't have time to get into much detail about that in this presentation, but it's super interesting if you want to look that up. Also, something to think about regarding cultural considerations is gender, that the assessments used for this disorder are mostly geared towards males. So that's definitely something to think about when it comes to diagnosis and treatment. So some literature on potential causes of this disorder. There are a variety of different theories as to the causes of pedophilia or potential causes to pedophilia. And the main ones I found were split between two camps. The first camp was biological and physiological causes, and then the second camp was psychosocial causes. So biological and physiological causes come down to genetic predispositions, high levels of testosterone, abnormal neurodevelopment in utero, lower IQ, and chromosomal abnormalities. And then with psychosocial causes, we have childhood sexual abuse. That's the most highly cited and prevalent influencer. And then we have abnormal or unhealthy early attachment styles or arrested emotional or psychosexual development. So moving on to assessments, we have the penile plethysmography, if I pronounce that right. Super controversial. Penile cuffs are attached to a pulse volume recorder that displays waves of blood to the penis during visual stimuli. This is also something that I don't have time to get into too much detail, but if you want to look it up, very interesting literature on that as to the reliability and validity and how that works. Viewing time does the same thing, except it's less invasive. In both of these assessments, mental health professionals basically show child pornography to people. So just something to keep in mind is that being in possession of child pornography is against the law, and so people can be prosecuted. Then we have the polygraph, also controversial with reliability and validity. And then we have different kinds of self-report measures and questionnaires. The ABLE assessment is pretty well cited. And here's a little image of the penile plethysmography. So differential diagnoses and comorbidity. Some differential diagnoses I found was antisocial personality disorder, alcohol and substance use disorders, and obsessive compulsive disorder. Some comorbidity, other paraphilias, and then both Axis 1 disorders and Axis 2 disorders. So these were actually very prevalent, very highly prevalent. One study found that Axis 1 disorders, specifically mood disorders, anxiety disorders, and substance use disorders, were comorbid 75 to 93% of the time, and then Axis 2 disorders 60% of the time, so very, very high. Treatments, so there's no cure for pedophilic disorder. Treatments generally aim to reduce acting on the urges, so the behavioral aspect of it, as well as distress and impairment through methods like CBT, behavioral therapy, and pharmacological interventions. So an example of behavioral therapy would be aversion techniques to suppress the attraction to children. And then pharmacological interventions aim to reduce the sex drive in general, and this took the place of surgical castration. And some examples of things that are used are SSRIs and a variety of different medications that fall into the androgen deprivation therapy camp, which basically just suppresses male hormones in general. So, case presentation to bring all this together. John was a spunky and well-rounded boy growing up in Los Angeles, California. When he was 9 years old, he was sexually abused by his teacher at school. For the next few years, he struggled with regulating his emotions. He began therapy, which helped him somewhat in emotion regulation. However, when puberty hit, John suddenly found himself fantasizing about fondling young boys about 5 years old. At first, he felt confused, and then a tremendous amount of shame and guilt and disgust. He was afraid to tell anyone, even his therapist, since he was afraid people would report him as an abuser. He was also attracted to girls his own age and even asked one out for prom. However, he could not stop his mind from fantasizing about the young boys several times a week, all throughout high school and into his first year of college. It was his shameful secret. He never acted on his fantasies and knew that he never would. However, the shame piled up, and by his sophomore year of college, he dropped out of school. So John can be diagnosed with pedophilic disorder non-exclusive type because he was attracted to both young boys as well as women his own age or girls his own age. He had sexual fantasies about prepubescent children, which satisfies criterion A. He never acted on his impulses, but he had distress and impairment, so that satisfies criterion B. And he was older than 16, and the children he fantasized about were more than 5 years younger than him, so that satisfies criterion C. A differential diagnosis could be OCD, since he had obsessive intrusive sexual thoughts. However, John does not satisfy the rest of the criteria for OCD, like compulsions, for example, so he shouldn't be diagnosed with that disorder, but instead he can presumably be diagnosed with pedophilic disorder. So discussion, which I'll post. Pedophilic disorder is highly stigmatized, and most people immediately assume that pedophiles will sexually abuse children, which has been a theme that I've pointed out in this presentation. Individuals suffering from this disorder are often afraid to seek help precisely because of this stigma. A group called Virtuous Pedophiles, told you I'd come back to that, has been created. The group consists of more than 2,000 members who are sexually attracted to children but committed to avoiding sexual contact with children. So I'd suggest checking out their website, which I linked over here. It's really interesting. They have personal essays that people wrote. Just reading through, their mission statement can be interesting. So my question for you all is, what do you think about a group like this? Relatedly, do you think it's problematic that pedophilic disorder is stigmatized, and why or why not? If you were a psychologist and a patient reported feeling sexually attracted to children, how do you think you would feel, and what do you think you might do? So if you want, you can answer one or all of those prompts. And here are my references. Thanks for listening, guys.